I'm Marcia Day Childress from the Center for Biomedical Ethics and Humanities, and I'd like to welcome you to today's Medical Center Hour, a program called Primary Care and Addiction, a Case for Social Leadership. This is the first Medical Center Hour of the 2016-2017 academic year. We're in an unusual location, although a lovely one, and we will be in our normal site next week, the Jordan Conference Center Auditorium, just across the way. I'm delighted to say that with this program, Medical Center Hour starts its 45th season. For 4.5 decades, this hour at midday and midweek has hosted some of the medical schools and UVA's richest conversations on current and sometimes contentious topics of common concern to medicine, healthcare, and society. One hallmark of Medical Center Hour's sustained conversation across the years is that it includes a healthy chorus of voices from our academic and professional communities, as well as public voices. You're all welcome. Let me say thanks for the School of Medicine's ongoing support, especially for funding from several endowed lectureships, including the John F. Anderson Memorial Lectureship Endowment, a gift made in 1955 by medical alumnus Dr. John Anderson. His gift keeps on giving a full 61 years later and counting. Thanks too to the Medical Center Hour's many partners, other medical school and university departments, the History of the Health Sciences lecture series, student groups, community organizations. The new year will bring us many shared ventures. And I'd like to thank you in anticipation, our audience. We welcome your participation in the 20 programs we'll bring you this year. Week by week, speakers and subjects will come and go, but at its heart, Medical Center Hour is really your forum. Please consider it so. It's your views and voices that make the Medical Center Hour the vibrant learning enterprise that it is. So please post the programs on your calendar, tell your colleagues and friends, and keep on coming. As in recent years, we're kicking off this new season by joining with the medical school's Generalist Scholars, students planning primary care careers, and with the Department of Public Health Sciences to observe Primary Care Week at UVA. Prevention and health promotion are part of the primary care message, and the apples that you will be receiving today or did receive in class are reminders of that. But primary care practitioners are challenged now to give frontline care to persons with very complex problems indeed that profoundly affect individual, family, and community health and well-being. One case in point is the present epidemic of opiate use, abuse, and addiction, an epidemic that's raging not only in Appalachia, but across Virginia and across the country. Our speaker today, Dr. Hughes Melton, Chief Deputy Commissioner of Public Health and Preparedness for Virginia, himself a primary care physician, and I'm proud to say a UVA medical alum, points out that today's primary care practitioners aren't actively engaged in treating addictions. In addition to offering his views on why this is so, he'll challenge us to consider what primary care providers most need in order to do this work, to care effectively for addiction in individual patients, to be sure, but also to address addiction as the daunting public health and population health problem it is, with grave repercussions for our cities, towns, and rural localities. What skills and attitudes must primary care practitioners have to best serve their patients? And what additional capabilities will enable them to take a robust social leadership role in their communities? Two of our generalist scholars will respond briefly to Dr. Melton's talk. Both Ahmar Hashmi and Vaishnavi Lanka, seated here with Dr. Melton, are second-year medical students, members of the class of 2019. I need to mention that none of our speakers had any financial conflicts of interest to declare. We'll reserve some minutes at the close of the hour for your entrance into the conversation as well. And now I'm delighted to introduce to you Hughes Melton.
Thank Marcia, can everybody hear me? Good. Nursing a little bit of a cold, so you have to forgive me that. Marcia and I go way back, as do Mo and I. Back to 93, when I was a medical student here, graduated in 93. We took a course that Marcia was teaching. And many, many fond memories. I stayed here in family medicine, and that's my graduating class here with Dr. Lewis Barnett. And then went off and practiced family medicine for about 20 years. And during that time, came to appreciate the importance of the chronic relapsing disease of addiction. Now, these are our learning objectives. And understand that 3 big topics, like we're going to tackle today, so primary care, addiction, and social leadership, we're not going to get into a lot of depth. So really, I'm hopeful that I will spark some interest, and there's of course much more out there, as you know better than I do, on the internet to learn about it and read about it. So that's what I'm really hoping that you'll walk away with today, a little bit of greater awareness of these 3 issues and what's the role of primary care and addiction and why social leadership is important. So Marcia mentioned that I'm in the role as Chief Deputy Commissioner, and I took that role 4 months ago. And when I first moved to Richmond, I didn't have a place to live. My family lives in Southwest Virginia in the Abingdon, Bristol area, and we decided as a family that they would stay there. My wife is a clinical pharmacist, loves her work, is doing great things in Southwest Virginia. My younger daughter will be a sophomore in high school and highly plugged in to everything going on there. And then my older daughter just matriculated as a first year here. And you'll see a picture of her at the very end. And so this is her 3rd week. So she would be here, but she has classes today, unfortunately. So we decided to do this super commuting lifestyle. And when I moved up there, I lived with my aunt for about 6 weeks. And about a week in, I arrived at the door to come home one evening, and she had stuck this to the front door. And evidently, word had spread in the community that a doctor was living with Beth Kinghorn, my aunt, and one of the kids had eaten a popsicle, because that's what this is, and they thought, hey, I'll share that. So I thought it was a great issue, example of the power of community, and a small sort of thing, but we're going to talk a little later about community. So let's talk a little bit about primary care. You talk to different people, you'll hear different definitions of what is primary care. This is the one from Johns Hopkins, Primary Care Policy Center. So I wanted to point out the all but the very uncommon. So when you think about what are the disease states that primary care ought to be focused on, it should be things that are not uncommon. Well, what is that? And we're going to talk about that in a second. Another way to define it, and the American Academy of Family Practice defines it this way, that we don't limit it by a particular problem origin. Okay, whether it's a biological or behavioral or social, if you're looking to do primary care, you need to be willing to engage with your patients on issues that aren't just physical, that have other etiologies and other components to the illness. Often we talk about the disease, that's the physiologic process that is happening. The illness is the bigger context. So, all but very uncommon. So just some statistics in terms of the prevalence of diseases that primary care often treat in terms of mental health, in terms of diabetes. And so when you look at addiction, it's right there. Right, so it's just as common as other chronic relapsing diseases such as mental health, depression, and diabetes. And so when you think about, okay, what are my tools as a primary care physician to treat? Diabetes, I have my lab tests, I have the history that I take. For depression, I've got some of the standardized screening. The same thing exists for addiction. So the science is out there that gives you the tools to screen for it, just like you would screen for depression or you would screen for diabetes, to screen for depression. And that's the opioid risk tool, the drug addiction screening test, the prescription monitoring program, and the urine drug screen. Same thing goes for treatment, right? Now, granted, 10, 15, 20 years ago, we didn't have much in the way of treatment for addiction, and that's often the case 25 or 30 years ago, we didn't have a whole lot to offer patients with depression either. And so science continues to come up with new modalities to treat, and there are effective treatment, there's effective treatment for addiction. And typical cure rates, so to speak, long-term remission, again, it's a chronic relapsing disease. We don't expect our diabetics to never get hyperglycemic. They'll be controlled for a while and something happens, and then their sugars get out of control, and they come in and they seek out help. Same sort of thing with addiction. And just like with diabetes, there are different levels of care. So certainly when you're doing rotations, you're going to be taking care of patients who are coming in an acute withdrawal on the inpatient side. Same sort of thing on the outpatient side. You have to match the level of care to the patient's condition. And the same thing goes for addiction. So I just want to draw those analogies because often, for whatever reason, there's the feeling within primary care that addiction really shouldn't be one of our main lines of treatment. And in reality, it's just as common as many of the other diseases that we treat. There are good tools out there to make the diagnosis, and there are good treatment options for patients who have that. Certainly there are patients with complex addictive diseases that need to be seen by specialists, just like diabetes, just like depression. But the bulk of patients can be treated by a primary care physician in their office, in a team type of structure. Just like we're learning more and more, and I got a tour maybe 2 years ago, the new learning area that the medical students that you get to work in. And we didn't have that when I came through. We'll tell you, it was all lecture hall, all didactic lectures. And the fact that you start off learning in teams, and then there's a very intentional effort to teach you the importance of the care team, nursing, pharmacy, social worker, nurse practitioner, PA. That applies to many, many, many different disease states, the value of that, the educator. Same thing goes for addiction. So let's talk a little bit about addiction. ASAM, American Society of Addiction Medicine, this is their definition. And I like to make sure, again, it's a chronic relapsing disease, and there are lots of different types of addiction, right? But they share a common pathway. And the pathway is the little red area in the middle, that's the nucleus accumbens, and then the arrow going up to the left, right, that's a dopamine pathway. So different substances come into the brain and hit different places, but they all end up coming into the reward center. They all end up stimulating dopamine, creating that sensation of reward. And so there's that common pathway which links a lot of different substance abuse diseases. And that helps when you're working with patients, that there's sort of you understand there's a common brain process going on within the patient. And science has used that to create drugs to treat addiction, depending on what the drug is. So there's Campril, there is Suboxone, there's Methadone, and there are other medications that have been developed to treat different types of addiction based off of what the underlying substance is and where it's hitting in the brain. So addiction in Virginia, not just in Virginia, but across the United States, really is at, in my opinion, an epidemic state. And when you see the statistics, back in 2012, 2013, more Virginians started to die from drug overdose than car accidents or homicides. And one of the things I want you to realize is that if it involved a different group or cross-section of society, I think we would see a different response to the statistics. So these are the statistics for ER visits for overdose. So the patient comes into the ER, chief complaint or discharge, heroin overdose. The light color is last year, the dark color is this year. So clearly you can see at least a 2 times increase in the number of ER visits just in the last 18 months. And that's just heroin overdose. The other thing is it's not the same across the state, and I'll talk about this in just a little bit. Some areas of the state have a bigger issue than others. And most recently, we're seeing a kind of an uptick in the Tidewater area. That's the high peak there in March, April, May, June. So that involves reaching out to the health departments there, the health systems there, the community service boards, and saying, what are you seeing? What do you think is causing this uptick? And then all drug deaths. This is data obtained by the Office of the Chief Medical Examiner. And you can see that steady rise from 2010. And what's been interesting, and I don't have these slides just to keep it briefer, but what's causing the overdose is changing. Just in the last 12 months, we've started to see prescription drug for opiate overdoses level off and actually decrease a little bit. And taking its place, and then some, heroin, and most recently fentanyl, and even most recently carfentanyl, which is a really potent form of fentanyl. You may have heard some of that in the news with large, in West Virginia, a week and a half ago I think it was, 26 overdoses in 4 hours, because that drug gets into the illicit heroin supply. The addicts don't really know it. They don't really know what they're taking. What they take is much more potent than normal. They present. All of those individuals none of them died from their overdose. Many of them were rescued with naloxone, used by first responders, the police force, criminal justice, as well as the rescue squads. But again, I asked the question, if we had another disease state that was affecting a different segment of population with this type of trend, would we have not seen a greater response? I think that we would have. So this is hard to look at, but the reality is that among professionals, physicians are actually in the higher bracket for frequency of substance abuse. Now, it doesn't end up being an overdose like this, which is good. We often have more resources around us that we're able to pull on to get into treatment. But the reality is, in particular with our anesthesia colleagues, the rate of substance abuse is the same as the general population, which you wouldn't expect with such a highly trained workforce. But in the area of prescription drugs, it's much higher than the public average. So we'll segue that to a little bit, happier story. So this is Dallas. Back in 2003, 2003, his wife came in, his mom came into our program. That's right. And started treatment, right? She wasn't pregnant at the time, and got stabilized in the treatment program, got pregnant, and had Dallas. Now, as you can see, Dallas has quite a few medical issues. He's got a trach, he had esophageal atresia, he had quite a few other medical issues. And I talked with his mom 3 months ago before I shared his story with the health directors for the state, and she kind of was giving me an update. She was just sharing about how, had she not been in treatment, who knows what would have happened to Dallas. And most likely he would have ended up in foster care if he were lucky, if something didn't really bad happen to him prior to the foster system picking up the situation in her household if she was still addicted and living that lifestyle. And so he's a kind of story of success and the difference that treatment makes. Anybody want to take a guess at the leading cause for foster care in Virginia? It's addiction. That's the leading underlying issue that drives CPS to get involved. So let's talk a little bit about what's been the response to what I would call an epidemic. So unfortunately, HHS says that about less than half of the 22 million people who need treatment for opioid addiction are actually getting it. That's just opioid addiction. If you look at the bigger picture of addiction, alcohol, the other substances, it's actually even lower than that. And in the New England Journal of Medicine article that's in the reference sheet, they talk about 40%, almost half of the counties in America they have no treatment services for opiate addiction. They may have it for alcohol, but they don't necessarily have it for opiates. So why is that? And in the AFP position paper, that there's copies outside if you want to take a copy with you, they talk about what are the barriers in primary care to treating addiction. And there are quite a number of barriers. And so I lumped them into 3 different groups: resources, knowledge, and community or environment, if you wanted to call it that. So let's talk about resources. The reality is that we're already spending money on the disease of addiction. It's just we're not spending it effectively. And so you can see in Virginia here, this is some statistics that we used last General Assembly in order to argue the need for the General Assembly to dedicate $12.5 million for some new benefits around addiction treatment in Medicaid. And they talk about, the average annual prison cost of a drug offender, $55,000, as opposed to getting them in treatment, a lot less than that. And that the return on investment for treating addiction is pretty significant. Every dollar invested, $7 savings to the healthcare and criminal justice system. The 2 red numbers point out that, and if you go down to status post MI, right, the total spend, as the insurance companies look at it, right, for status post MI, $14,000, and for substance use disorder, it's $1,500, excuse me. So $1,400, $1,500. But if you look at the medical and behavioral, they're not spending the money in the right place for substance use disorder. That needs to be over in the behavioral column. And that represents the patients coming into the ER with an overdose, going up into Rose ICU, intubated, etc. And then going home with what? Often no ability to find follow-up treatment for their addiction if they want that. So the money is being spent. This is a really busy slide, I know you can't read it, but basically it talks about the money the GA Assembly put into Medicaid for addiction treatment does 2 things, mainly geared towards establishing parity. You may have heard of parity in terms of insurance coverage, and there is not parity in insurance treatment for addiction. They don't pay for some of the services at all that the patients need in terms of like recovery coach support. And then also what they do pay for counseling for addiction is actually less than what they would pay for mental health counseling. And so this whole benefit is geared towards rectifying that situation. So paying for the services that somebody with addiction needs, and also increasing the payment to try and remove that financial barrier that primary care physicians have been looking at and thinking, I can't get into treating patients like this. I can't pay my staff that are required in order to provide the care. They're going to be, this rolls out over the next, at the bottom you can see sort of the timeline. Right now we're in the midst of educating kind of health system and practice leaders on what the benefit is and the opportunity for them to get reimbursement equal to or if not more than what it costs them to provide the care. And then you'll see in February, March, and April at the bottom, we're going to be doing regional trainings, and I'm working with some of the local residency programs to try and get the residents out to those in order to just increase general awareness as well as to give you some of the tools that you need. So I was saying that, I believe that addiction is a public health crisis, and in the AFP position paper, they talk about we need to respond at 5 levels. That's a little too complicated for me as a primary care doc. I like to keep it simple, so I break it into sort of a local and a large scale. And this is where we get in a little bit to some of the social leadership issues. So a local response, I would argue, is kind of the physician level, practice level. What am I doing in my own world around the fact that I'm seeing these patients already? They're just coming in and driving me crazy because I don't know, don't have the tools to deal with them. It's like somebody coming in to see you for diabetes and you have no lab testing, no insulin, and no oral hypoglycemics. If you've ever worked in a third world, sometimes you run into frustrations like that. And it's not a very good feeling, and that's a barrier. So you need to respond to that local response by increasing knowledge. Anybody want to take a shot at the first word? what that means, where it comes from. No. So it's Latin. To teach, right, exactly. So it's the root word for doctor. And I always like to think as a physician, and you know this better than I do because you're in the midst, is you need to make sure you're educating yourself. So I would argue that for a disease state that is as common as depression, as common as diabetes, every healthcare provider needs a pretty good working knowledge of what's going on in that disease state. So what do all those presentations have in common? What do we think the underlying disease is? Let's take any first years. Which ones? Second years? Mo's my go-to person if we can't. So they all share the same diagnosis. Anybody? Diabetes. Very good, thank you. Yeah, diabetes. So what I would say is, for those of you sitting in your chair going, what is that? And for those of you who've taught, right? When you get a presentation from somebody who doesn't fully understand the condition that they have seen and are showing to you, you kind of get that, why aren't they getting it? Why can't they see that this person obviously has diabetes? And it's as simple as a limit in their knowledge base and their experience. And so I think as providers, we experience the same thing when it comes to addiction, because our knowledge base is often not what it needs to be, and our experience is also not what it needs to be. We haven't had the opportunity to work in an outpatient environment or inpatient and treat patients. So this was our local response. This is our clinic in Southwest Virginia that my buddy Brian Easton and I started back in 2000, and I worked there until 2012. And everybody knows in Southwest Virginia, major prescription opiate epidemic. And about 2 years in, we're like, what's going on? All these patients coming in asking for Lortab. And we didn't experience that in our residency program here with Sue. So we go, all right, what are we going to do? We can just tell them, go someplace else. Or we can decide, well, no, we're going to become part of the solution to that problem. So I actually called up here and spoke with some of the attendings here who had some knowledge base. We started working with our patients who were pregnant, dealing with neonatal abstinence syndrome long before it got into the kind of mainstream. And also got involved in a treatment program up the road that was a methadone treatment program. The Suboxone really wasn't out until a little bit after that. At least I didn't get involved with it. This is a younger me treating one of my patients with addiction who's pregnant. And I will tell you, treating patients with addiction who are there for treatment for their addiction, as long as they're in the scamming mode, they're very challenging to work with, right? But if you can transition into treatment of their addiction role, of their addiction disease, it is one of the most rewarding areas of medicine that I've experienced. And I'm not the only person to say that. It has its challenge. Like I said earlier, 50% long-term response rate. That means 50% of the patients, they're going to relapse. They're going to not come back. So that's the nature of the condition. But that's the nature of a number of the conditions that we treat. And we just accept that that's part of the disease, whether it's cancer or some other type of terminal or difficult to treat illness. So that's the local response. So I want to pause just a little bit. Let me get everybody to stand up. Stand up. Stand up. Get the blood going a little bit. All right, excellent. I'm over to all right, excellent. All right, grab a seat. So we've covered sort of primary care. What is primary care? What's some of the basis of addiction? How big is the problem? What can you do locally in order to, what are some of the barriers, right? 3 barriers. What are some of the what is some of the work being done to address those barriers in terms of payment reform, in terms of local knowledge, or local issues, your practice, your local environment. So I want to transition into the bigger picture and end on this issue of social leadership. The reality is that the health of your patient is determined much more than by just what you do for that patient in the exam room. Now, I'm not going to underplay the importance of that work that we do in the exam room with the patient or in the OR with the patient, But the reality is that when you're looking at what drives their well-being and what drives their life expectancy, there are many, many, many other factors involved outside of just your exam room in the house of medicine. So I think it's important for physicians to recognize that and have an appreciation for the work that's being done outside of just the kind of the halls of our medical system. So Virginia, there are really two Virginias. And this is life expectancy in years. So why is it that where I live and where my brother lives in Farmville, their life expectancy is 10 years less than in Northern Virginia, which is where I grew up. And there are a number of reasons for that. And again, it goes back to what I just said. There are factors at play outside of just what we do in our regular in the exam room work that is driving that. They're often called socioeconomic factors, health behaviors, which is often addiction related, whether it's smoking or overeating. Obesity shares actually a lot of the same neural pathways as addiction to other substances, especially with highly processed foods. And high fructose corn syrup hits a lot of the same receptors in your brain. And so you have to realize that in order to understand what's happening in these areas. So a little plug for the health department. I have to say that before I started working in the health department, I had very little, started looking at getting into that. I had very little appreciation for the work that they did. And I tell them, in fact, we were meeting this morning for our sort of check-in in the morning for all the deputies and leadership team, and I said, it's like we're in the movie Men in Black. that they're doing all this work to prevent, you would not believe the number of different diseases and illnesses that are out there just waiting to break through, those efforts and measures being done to prevent that from happening. And so, lest you think that it is a sleepy type of work, it is not. It's just sort of silent and in the background. But I would encourage you, when you're looking at your potential career path, spend some time with one of the local health directors as part of first, second, third year, whenever you have that opportunity. It really is a very exciting area of medicine. I've got a little video we'll show here. So, along the lines of trying to get some alignment in addressing the bigger picture, socioeconomic factors, health behaviors, the state has come up with a plan for well-being, which I can hopefully bring it up here. All right, so they talked about the 4 aims, and the whole idea is to get at the bottom of the pyramid. And to get, the challenge with the bottom of the pyramid is that they're big issues that involve lots and lots and lots of different stakeholders. And that's where we get into social leadership and community response. So when we talk about community response, and there are copies of the plan, you're welcome to them. They're down here. Grab one on your way out if you're really interested. If not, then don't take one because they're not free. And collective impact is the concept of bringing together lots of different sectors in society. So that could be IT, that could be manufacturing, that could be transportation, not just healthcare, and get them to commit to a common agenda like a plan for well-being, using some type of shared measurement so we can actually know where we're trying to get to, and then you're trying to solve one of the big social problems. And what's interesting, I was talking with some of the general scholars earlier, and actually, how many are general scholars? Just 10, great. About how what's interesting about this is we do this every day, especially in primary care, but really in medicine as a whole, we're often reaching out to different specialties, right? We're often agreeing on a common disease that we're trying to treat. We're using a shared measurement system, whether it's an understanding that we're trying to increase the hematocrit or decrease the A1C or whatever the case may be. And then we're trying to solve not a social problem, but a physical problem. So it's interesting, it's sort of the same muscles, but it's a little different focus for physicians. And as a general rule, at least historically, physicians were trained more on task leadership, less on social leadership, which we're going to talk about in just a second. Now that's changing, and I know that the med school curriculum has come a long way. So you guys are further ahead than I was when I went through medical school. And it's a key skill. So the definition of social leadership is similar to what's required to make collective impact happen. And it creates something called social capital, which I had very little appreciation for until I met John at Lee, Virginia. And the value of social capital that sort of greases the underlying ability of individuals to work together, to give a little in order to get a little, and be able to kind of go as a group in one direction towards a common goal. And I mean, you've experienced this, right? Your first rotation, your first day on the rotation, you don't know the intern or the attending, you never met them, right? And so it's harder than 2 weeks, 3 weeks into the rotation. You've gotten to know those individuals, and the communication is facilitated about that. If they ask you to do something that's not necessarily, what you think is your job to do, then you're going to be more likely to say, okay, I'll do that for you, because you've gotten to know them and you respect them and understand they're asking you for a good reason. So it creates social capital. And I'll just point out that in Dean Canterbury's August 2nd blog, he was talking about leadership and how they're seeking to build that into the medical school curriculum. And he broke it into 4 domains: personal, interpersonal, I would call that local knowledge sort of component of leadership, and then system-based social leadership, interacting with sort of the broader world. So just sort of a diagram around social leadership and what it involves. Often you have your formal spaces, but you have your informal leadership that is necessary. And you have to have the ability to work in both communication channels, both leadership channels, and understand sort of the unwritten rules and the norms that exist there in order to be effective. So back to the kind of 2 Virginians, and just sort of a challenge to you and to UVA. I have a number of friends of mine who work here in the addiction sphere, but not very many, because unfortunately I don't believe that UVA has led the way it could on this issue in particular. And I'm hopeful that will change with time, but the reality is that the medical education that is occurring, the experiences the residents are getting, and the actual care provided by the health system is, in my opinion, not where it needs to be. And I wanted to close on the issue of health opportunity or equity. The reality is that there is much more investment in resources put into some areas of the state than in others, and in some populations than in others. And I would argue that one of the reasons that investments haven't been made for this population is it's poorly understood and not respected, for lack of a better word, And the reality is, when you learn about it, it cuts across all socioeconomic sectors of society. You just don't see it often in the more socially economic, economically affluent, because they get into treatment, they sort of hide it. You don't see it till they die of an overdose. You can make a couple different arguments for why we need to seek equity. So this is making an economic argument, because at the bottom you see there's disproportionate spending for the medical care for individuals who are in a low health opportunity area. The Health Opportunity Index is a metric that the health department has developed from 13 different metrics that they kind of pool into one. If you're interested in it, just shoot me an email and I can give you more information on that. But we're already spending the resources, but we just need to spend them smarter in those regions in order to have an impact. But I would argue that really it's more of a moral argument. So this is Dallas a year ago, I think, and I think that not that we expect to make everybody equal, right? I don't think that's realistic, but I do believe that we need to come at issues where there is lack of opportunity and invest disproportionately in order to provide equal opportunity for individuals as much as possible. Whether they take advantage of that, is often out of our control, but I think we need to lead in a way as physicians that is our what we call for. And physicians, I believe, are in a unique situation to be heard on issues like this in meetings and in environments where they have a lot of respect, only they can go. So many of the patients with addiction, they never get heard. And so in a sense, we need to be willing to speak for them, whether it's on the Chamber of Commerce or whatever group you choose to plug into. So I leave you with that challenge. How are you going to plug in and lead outside of just the halls of medicine? And I hope that you will consider the value of social leadership in making a difference in the health of the population in Virginia. Thank you for your time.
Now that you heard from a well-regarded expert in the field, you are primed to take in the wisdom of two students with just over a year of medical school under their belts. But on a more serious note, we are excited about the chance to discuss things from our perspective. So we'll start with Vaish.
First of all, I'd really like to thank Dr. Melton for giving us his time and talking to us. I'm sure most of my colleagues will join me in agreeing that this is a pressing topic that needs to be addressed. From a perspective of a second-year medical student, I feel like our training teaches us how to recognize the substance abuses. We learn the pathways in the brain. We know the acute drugs such as naloxone and how to treat acute toxicity. We know how to recognize the withdrawal symptoms and the signs of overdose. But I feel like it's a lot more challenging to learn how to chronically manage such a condition. And to all the first years out there, you will learn all of this stuff by the end of your first year in MDB. But coming back to the point is, as Dr. Melton mentioned, substance abuse is just as pressing as a lot of the other chronic conditions such as diabetes, hypertension, and asthma. For instance, they have the same relapse rates. So I feel like it's very important for us during our medical education to not only focus on the acute signs and symptoms that we're going to be tested on, but also trying to develop the techniques on how to manage long-term care for these patients, including motivational interviewing, setting goals, making follow-ups, and plugging into the local system and incorporating the community factors around us. Along with treating the chronic component of substance abuse, I feel like preventing it is also a big point in treating it and making our community better. There are some statistics from the Addiction Center that I wanted to share with you guys. Half of all new drug users are under the age of 18. 20% of 12th graders report binge drinking, and 20% of high school seniors report using marijuana. Particularly, what's relevant to this talk is 20% of teens have abused prescription medications, and 40% of those teens have gotten the prescription medications from their parents. So and this is global, I'm sure this problem is a lot worse in the lower socioeconomical regions such as Southeast Virginia. So primary care physicians have a very unique, are in a very unique position and have a responsibility to mitigate substance abuse through advocating prevention and managing long-term care. And I'm going to hand it off to my colleague, Ahmar.
So something that wasn't touched on too much during this talk was the role of physicians in this particular crisis that we have now. And although there are a lot of different factors that go into it, we have to take some accountability. So physicians have to take some responsibility as they played a role in the culmination of the prescription opioid epidemic through overprescription. So yesterday we had a really important talk as part of Primary Care Week where we discussed different models of primary care, whether that included direct primary care, having a blend that included academic medicine, and a practice which incorporates home visits. For me, a salient point that was made was not all the different ways of doing the job of a PCP, or primary care physician, but as to the why is it necessary. What is it about the job that necessitates developing different models and finding new and better ways to see and treat sick patients? So a recurring theme that comes up not only in primary care, but across many different specialties, is the need to see a lot of patients in a relatively short amount of time. We have to take into consideration the consequences of caring for a large population of patients and not always having the time or the vision to see drug-seeking behavior or even drug dependence. It's difficult to counsel a patient and sell him or her on an alternative holistic treatment strategy to deal with their very real pain if we have such a narrow window of time to do everything. So the point that Dr. Melton addressed was the need for PCPs to be at the forefront of this very important issue. And I strongly agree with this because primary care physicians have a unique relationship with their patients. PCPs have the privilege to treat their patients across a long period of time and therefore are able to form a relationship that extends beyond a cordial respect to a sincere type of friendship. This puts us in the best position to understand the things our patients deal with on a more regular basis. In our personal lives, we deal with a multitude of factors, and if we didn't have an adequate support system, perhaps we would have fallen into some of the same traps that the less fortunate individuals do, just as Dr. Melton referenced with the two Virginias. You know, socioeconomic status and access to education are important factors that led to this crisis. So a PCP is better equipped, I think, than any other type of doctor to pick up at-risk patients and therefore more quickly initiate a potentially life-saving course of action. So that's pretty much all I had to say about that.
Thanks to all three. We're going to have them seated at the panel desk there, and it's now your turn. So don't be hesitant. Use the mic in front of you. You'll see there are little sketches there that show you where to press to talk. And so this will be, from now on, an open conversation, and you may direct your comments or questions to any or all of the three panelists. And please identify yourself, if I haven't. No, please identify yourself when you...
So I'm Mona Carney in General Internal Medicine. So welcome back, Hughes. It's good to have you.
Thanks.
I want to welcome you to something else. On November 4th, we're having a work group on pain management and opiate overuse that's bringing all the stakeholders together at UVA. So my question to you is, and to the students, is if there were three things that UVA could do to lead to help stem this epidemic, what countermeasures do you think UVA could lead with best?
Great question. Great question. So I think one of the challenges with treating addiction is that it's one thing to read about it in a book, but it is one of the diseases that you really need to experience. And I just don't see that opportunity in the, I wouldn't say Charlottesville, of course, UVA is much bigger than just Charlottesville. But I think there needs to be investment in a quality outpatient addiction treatment venue of some form or fashion. And I don't think that necessarily it has to be a particular department. You know, it might even be an opportunity for family medicine to partner with internal medicine. Who knows? Right now what's happening, because I just spoke with one of the OBGYNs affiliated with UVA on the way here, is it's very piecemeal. And if you talk to the physicians who are doing it, they feel very isolated and very vulnerable. Partly because of some of the community issues and sort of how their colleagues are looking at them. I mean, it's sort of one of those areas of medicine that you need some comrades to support you. And so I think some, that could be, just an investment of green light by leadership at UVA, that those steps are expected, and then maybe even an investment of resources necessarily to sort of get that going. And then that place would be where students and residents can go to get some of the practical exposure to the way addiction treatment really is. And it's not often what you see in the movies, and it's not what you see on the inpatient detox or psych wards. It really looks very different when it's done well in an outpatient type of environment, and that's where 80% of it needs to happen. The other 20%, sure, inpatient detox and that sort of thing. But where we really need the workforce is outpatient treatment. Let's see. The other thing I would argue would be, and I have to say I have to speak a little bit from ignorance, is aggressively engaging with the other stakeholders in the community. So the CSB, not just in Charlottesville, but in the surrounding area, and how can UVA work with those entities that are trying to make a difference, health department, community service boards, and partner with them in some form or fashion. Often they have part of the solution. So for example, in our area, the CSBs, excellent counselors, excellent recovery coaches, they have a real hard time finding physicians who will provide the medication-assisted treatment component of that entire team that's needed to see that 40 or 50% long-term remission rate. So that's two. You guys have one?
Yeah, maybe just earlier intervention in the medical education process. So one of the great things that the School of Medicine does is we have these patient presentations where we get to assign a name, identity, and a personality to a particular disease. But one of the things that we haven't really experienced is a patient presentation where someone with an addiction to a substance comes. And I think having that and exposing medical students early on would really make it a more prominent issue and maybe lead more people to take an active approach towards solving it.
Thanks. Thanks.
Is this on? Yes. Karen Knight from the Health Sciences Library. Unlike the analogies you were raising on the other chronic relapsing conditions, this one has a legal component. And the fact that many of these substances are illegal, what complication, obviously, does that throw into the care and solving this issue?
Good question. So, I mean, there are a couple of facets to that, right? One is you're dealing with a population of patients who live in the world of that, who are familiar with living lifestyles that involve them breaking laws. And so, I mean, there is some concern there, although I have to say in my entire career I've only had one patient that has, made threatening remarks and comments to me, and actually I think that was a chronic pain patient, not so much an addiction patient. So that's one facet. I'm not sure if that was where you were, or what you were thinking. The other facet, and then I'll let you kind of clarify if I don't hit what you were thinking. The other facet is that these substances are under a lot of scrutiny, even the prescribed opiates and the prescribed medicines used for medication-assisted treatment. And we read a lot about physicians losing their licenses because of their use of the medications. And I would argue that if you talk to the Board of Medicine, who is the one investigating and pulling licenses, if you are good in your documentation and you're following the guidelines that are out there, you're fine. Now that's not to say that they're not gonna, somebody's not gonna complain. Again, a little challenging patient population, they tend to complain, right? That you're not gonna get a letter saying there's this complaint, send us 5 records, it has XYZ. They have to investigate that, that's their job. But I have quite a few colleagues that sort of freaks them out, for lack of a better word. But I say, if you're documenting well and you're following the guidelines that are out there, the standard of care, you're fine. And that's the way that it turns out. They look into it like they're supposed to, and it ends up being fine. Was that what you were?
I think I was also, I think that was a very good point. That wasn't what I was thinking. I was thinking more about the fact that this population already has to live somewhat under the surface.
Right.
And so they're not as forthcoming perhaps in the patient process or even discoverable by healthcare workers. And I don't know what the answer is to that.
Great question. So you'll find, my experience in the exam room is patients, once you go there with them in a caring sort of way, it's amazing what they will be honest about. So in terms of having to sort of tease out the truth of what's going on, I mean, it does take a little more work. But for the most part, they're willing to be honest about the behaviors that are illegal. Now, you do sometimes lose patients. They don't come back, and you call their family member, and they say, well, they're in jail. So, I mean, there are issues with things happening in their life that get in the way of the therapeutic relationship. So that is a complicating factor, but it's a minority of the challenges in treating the patient population. They do have socioeconomic challenges to get to the appointment in the first place, but that's not necessarily different than other patients with chronic diseases who don't have much of the resources. Yeah, thank you.
I was curious as to your thoughts on the small trends within, oh sorry, I'm Monty, I'm a first year medical student. I was curious as to your thoughts on the trend in some parts of the country to adopt more liberal, somewhat Scandinavian policies towards drug use, and particularly on the part of the police, and what your thoughts on the efficacy of these more liberal policies.
Good question. Yeah, you know, I think the jury, it's tough, right? Those of us in the addiction field cringe when we see an increase in uses of substances like marijuana, for example, some of the, what I would call sort of experiments occurring in other states in the country. Only because, again, it's a disease that shares common neuro pathways, and so the more substances that you're addicted to, just there's reinforcing of that. So that's not really a great answer to your question. I think what they have going for them in some of the other areas in the world, as well as in America, is at least they understand that it's not a lifestyle choice for patients who have the disease of addiction. Now, they did make some bad choices at the beginning, right? But the reality is that once they get into the disease of addiction, it is a chronic relapsing disease, and their brain is actually, it's wired differently, they think differently, and so therefore when you start to interact with the patient population, they don't respond to the common interventions that are done in the criminal justice system. So you'll talk to what I would say are enlightened individuals in the criminal justice system, and they'll say you can't arrest your way out of this problem. And because the disease, the nature of the disease impairs the individual's ability to make somewhat logical and rational decisions, similar to mental health. The biggest caregiver for mental health in Virginia is the criminal justice system, and so you can't approach those individuals as if they're going to respond to your intervention like you would, because that's not the way that their brain works. So that's, in terms of like the outcomes that they're seeing, I'm not as up on the statistics and the data on that.
Have programs like needle vending machines or exchanges been considered in different parts of Virginia where this is more of a prominent issue?
So I do know some of the data on that, and when you look at the impact of safe syringe program or needle exchange, you can call it different things, it's pretty amazing in the states that have put those services into place. And so we're working hard at Enrichment on trying to educate decision makers, legislators around the value of some of those harm reduction. That falls into sort of the big bucket of harm reduction. And approaching the population from the perspective of, if you're not going to stop, then how can we make it so that you are less likely to overdose, less likely to pick up hepatitis C or HIV, and safe syringe programs have, along with the things that come with them, the education, some areas have gone so far as to sort of give a safe haven for places for individuals to use. So they come in, they'll use, and then they go about their day. And if they have an overdose, if they get a substance that has carfentanil in it, and they go from breathing to not breathing in 30 seconds, then somebody's there with naloxone to rescue them. And sometimes that opens that window where they'll go, I don't want to live this way anymore. Those have been shown to be effective, but hard for society to understand and accept. Thank you for clarifying.
I think we're out of time, but I think the other thing that I took away from these presentations, and I'm reminded of one of the things that Ahmar put in his little bio, is the importance of the trust between the primary care practitioner and the patient around illnesses that have this kind of sensitivity and this kind of chronicity. Thank you, all three presenters. Thank you for this program, and please join us next week. Again, we'll be back in the Jordan Conference Center auditorium for a dog walks into a nursing home, what we can learn from animals in a medical setting, with Sue Halpern, who'll be here from Middlebury College in Vermont. Thank you again, and have a good week.